And I'd like to yield to Ms. Herrera Butler to introduce Dr. Sasha Kramer.
Thank you, Madam Chair. It is my pleasure to introduce Dr. Kramer. Dr. Kramer is a resident of Southwest Washington. She serves Olympia, which is the northern part of my district, on I-5, if anybody wants to know where that is. We are in between Seattle and Portland, but we are neither Seattle or Portland. Serves in Olympia and the surrounding areas in the field of dermatology. After completing her residency at Geisinger Medical Center in Danville, Pennsylvania, Dr. Kramer moved to Olympia in 2005, where she now lives with her husband and 2 sons. In May of 2009, she opened her own practice and has been an asset to our community ever since. Dr. Kramer, thank you very much for coming today, and we look forward to your testimony as we move forward.
Good morning, Madam Chairwoman and distinguished members of the committee, especially Congresswoman Herrera Butler, who represents my hometown of Olympia, as she said, Washington. And my name is Sasha Kramer. I'm a board-certified dermatologist, and I appreciate the opportunity to talk to you today about health information technology and the challenges that are facing physicians surrounding the selection, purchase, and implementation of electronic health records in their practices. So as Ms. Butler mentioned, 2 years ago, I opened my own practice in Olympia, where I currently employ 2 full-time and 1 part-time employee, and I see an average of 125 patients per week, with 40 to 45% of my revenue coming from Medicare and Medicaid. Over 2 years ago, I invested in an EHR system at a total cost of about $41,000. I did receive a $20,000 grant funded through the Washington Health Information Collaborative for Health Information Technology, and paid for the remaining $25,000 out of my business cash reserves. As a solo practitioner, I was fully responsible for the research, selection, and implementation process of the EHR vendor and system. Initially, during system implementation, my patient volume was dramatically reduced in order to accommodate the learning of the system by myself and the staff. It did take me about 4 weeks to return back to my normal patient schedule. However, 2 years later, I'm faced with the system where I have to completely reinvest in a new system. Approximately 1.5 years after I implemented my original system, my software vendor was acquired by another company that will not support my current network platform. Now I have no choice but to purchase a new system that will cost approximately $30,000 with $6,000 in annual charges. And aside from the financial investment, I once again have to take time away from my patients to implement and train my entire practice on this new system. Having said this, I fully support the use of health information technology. My practice and patients benefit from HIT in a number of ways, including improved patient safety, increased practice efficiency, and simplified claims processing. While I see these as benefits in my practice, there are significant barriers to full-scale adoption and implementation of HIT, including cost, regulatory barriers, and financial penalties and system integration. According to the American Medical Association, the average cost of an EHR system is estimated to be $30,000 per physician, with an average maintenance cost of between $3,000 and $15,000 per year. This is a significant barrier for a specialty like dermatology, where over 40% of the practitioners are in private practice or solo practitioners, and half are in rural areas. Physicians seeking investment capital are having issues finding a lender willing to provide them with an unsecured loan. Others may attempt to finance their HIT system purchase with the vendor, but small practices like mine have little or no leverage in negotiating the terms and rates because of a limited market share. My practice is a great example of the unpredictable marketplace, as I will have invested over $53,000, which would have been $73,000 if it weren't for the grant, in 2 different systems over just a 3-year time period. In addition, there are regulatory burdens with financial penalties that could hurt the full-scale adoption of HIT. Dermatologists and other providers are struggling with the CMS meaningful use timeline. For early adopters who have a contract with a service provider to meet 2011 and 2012 requirements under Phase 1, there will be a very short window between the release of Phase 2 requirements and the deadline for meeting them in 2013. Furthermore, physicians are facing financial penalties on their annual Medicare billables by 7% of 7% by 2017 if they're not in compliance with the meaningful use criteria, the physician quality reporting system, and e-prescribing. This 7% could be a practice's entire profit margin and could make the difference between a practice staying open and a practice closing. Simply understanding and implementing all of these different programs is extremely difficult and often overwhelming, especially to a small practice. In improving HIT adoption across dermatology, I urge the committee to address 3 issues. Number 1, provide sufficient financial and other resources so solo physicians are able to select and implement HIT systems. Number 2, consider delaying the penalties associated with HIT adoption until such a time as a functional integrational system is in place. Short of that, consider grandfathering in some physicians and exempting them from financial penalties so that they're not pushed into early retirement, which could further exacerbate the physician shortage in this country. And number 3, if penalties are not delayed, provide a safe harbor for those early adopters of HIT to protect them from financial penalties related to the meaningful user requirement. They should not be punished for the failure of their EHR vendor to implement new criteria. In closing, I will absolutely continue to incorporate HIT because I see its benefits to my practice and patients. And I look forward to working with you, and thank you for the opportunity to testify before the committee today.